Okay, assalamu alaikum, ladies and gentlemen. My name is Omar Ahmad. I'm a fourth-year medical student, and today I'll be giving you a session on degenerative diseases. Okay, so you've already taken 3 hours on this topic, 2 hours with Dr. Uban and 1 hour with Dr. Al-Kawi on the clinical side of this. Okay, so I don't want to keep repeating the same thing they've already repeated. I'm sure you already understand what they've said. So instead, I'm going to do two things today. One, I'm going to show you what the high yield information is, so you can keep the high yield information there, what to focus on, okay? And number two, I'm going to make you be able to use that knowledge and put it and like utilize that knowledge, okay? Because a lot of you have knowledge, you know everything from the lecture, but you don't know how to use it in a real clinical scenario in the exam, okay? So that's what I'm going to show you today, okay, inshallah. So we have a few topics to cover. We have Parkinson's, we have Alzheimer's, neural pressure hydrocephalus, vascular dementia, ALS, and some other diseases. Okay, inshallah, we'll be talking about that. I'll be focusing mainly on the clinical sides of these topics, as you've taken the pathology in with Dr. Alban. Okay, I'll also try to dig in some pathology. Okay, so let's start. Bismillah ar-Rahman ar-Rahim. So, like I said, we're going to be doing questions. I don't know if I said that. So this is the first question. Go ahead, guys, read it. And when I see answers in the chat, I'll start discussing it. Oh yeah, I didn't put the choices yet because I want you to think of it without the choices. Okay, so let's go. Let's dive into the question. Okay, let me read it. So a 59-year-old woman. Okay, so once you see 59-year-old, you want to put in your head what are the differential diagnoses in terms of the epidemiology. Okay, so you know Alzheimer's disease, it's usually 65 and above. Most questions will be in their 70s, some in their 80s, and then some rarely in like 68, 67. 59, a bit too young. So you want to put Alzheimer's to the side. You're going to be thinking of something else instead, okay? So let's go on. A 59-year-old woman comes to the physician because of progressive, okay? Look, see, these are the words you need to focus on. Progressive, what does that mean? It means it's chronic, it's taking time, okay? It's not a rapid. Why you have to know that? Because there's some diseases that are rapid, some diseases are progressive, okay? Progressively worsening coordination and involuntary movements in her left hand. For how long? For 6 months. So it's something gradual, okay, occurring over 6 months, just her hand getting worse, okay? Her husband also reports that she has been withdrawn and apathetic during this period. So we've seen two symptoms, two signs so far, okay, of disease. One, movements in her hand. What is that? That's motor. That's a motor problem. Number two, withdrawn and apathetic. What is that? Okay, that's like more mental, something related to the person's mentality. Okay, apathetic. What does apathetic mean? Apathetic means like, you know, he's just not there. Like he does not have any emotions on his face. It's like he's a poker face. He just does not have any emotions on his face. You don't know what he's thinking about. Okay, that's what apathetic means. She is oriented to time, place, and person. Examination shows a bimanual. What does bimanual mean? Both hands, bilateral, okay? Rhythmic, low-frequency tremor that is more prominent in the left hand. What does rhythmic mean? All these words have a meaning behind them and have a reason they put it there. Rhythmic basically means a coordinated movement, right? You know that, common sense. Why is it important to know? For example, a rhythmic movement is when you're doing this, okay? So watch my hand. It goes back and forth, back and forth, back and forth. That's rhythmic because there's a rhythm, okay? But if I go back and then up and down and left, there's no really rhythm to that. Why is it important to know that? Because some diseases have a rhythmic movement, other diseases don't have a rhythmic movement, they have a non-rhythmic movement, okay? So let's move on, okay? So there is a normal range of motion in the arms, legs. Active movements are very slow. Muscle strength is normal, and there's increased resistance to passive flexion and extension in the limbs. What does increased resistance mean? Okay, increased resistance to flexion, that's basically called rigidity. Okay, so like for example, this is a normal person moving his wrist, okay, like just easily, just smoothly, right? But in a patient like this, it's going to be very hard. Like when you're moving it down, it's going to be very hard. It's going to be like that. It's going to be stiff, okay? So that's the difference. So that's what, yeah. Okay, she walks with a shuffling gait and takes small steps. That's another sign. Which of the following is the most likely pathology causing this patient's presentation? So now can someone please type in the chat what you think the answer is? A, B, C, or D? C, yes, correct. Degeneration of dopaminergic neurons. What is that talking about? That's talking about Parkinson's disease, okay? So now there's a lot of words here. You probably didn't understand much. Okay, let me move on to this next slide. Okay, so these are the main words. These are the pathologies, the clinical features you see in a Parkinson's disease patient. Bradykinesia, pill rolling tremor, rigidity. These words kind of sound kind of weird, so I thought I'd show you this. I'd show you a video of this. Okay, so can you guys still see my screen? Okay, can you see the video right now? Okay, I think you can. Okay, so let's start. Let's watch the video. Okay, this guy's he's a patient with Parkinson's. Okay, let's see what he's trying to do. What's he trying to do here right now? He's not trying to do sujood. He's trying to get up. Okay, look how long it's taking him to get up. He's just trying to get up. Look how long it's taking him. That's called bradykinesia. So that's bradykinesia. Brady means slow. Kinesia is movement. So you have slow movement. So the patient is very slow in getting up, so that they could see in a clinical scenario that the patient, he feels very, or on physical exam, you look at the patient and he takes a long time to get up from the chair. They could say that, I've seen that happen. What they're trying to say is that he has bradykinesia. They're trying to point at Parkinson's disease, okay? Second thing they can see is, look at his hand. That's a pill rolling, that's a tremor, okay? He's shaking it like that, okay? That's a pill rolling tremor. It's very important to know two things about the pill rolling tremor, okay? It subsides with voluntary movements. What that means, I've seen a patient myself. He had a pill rolling tremor. When we gave him water to drink, his tremor became better, okay? And it's important to know that. Why? Because we have multiple types of tremors. We have intention tremor, essential tremor, okay? Pill rolling tremor. These three tremors, they will literally ask you a question. They will give you Parkinson's patients and they'll tell you what type of tremor will this patient have. And you say a tremor that subsides with voluntary movements, okay? So, and during rest, there's a tremor. With movement, it subsides, okay? Rigidity, I explained. Shuffling gait, basically, like if you get up right now and you walk, you'll find your hands will be moving like that, okay? You'll be taking big steps. These patients, they'll be taking very small steps. Their hands won't be moving, okay? It's gonna be next to their side, okay? They're so stiff and rigid. So these are the clinical features of Parkinson's disease, okay? Now, I want to put some pathology in because that's also very important. Please don't forget the pathology. We have destruction of what? Dopaminergic neurons in where? The substantia nigra. Substantia nigra, it looks black because of the melanin. So on autopsy, it's going to be, it's not going to be black, it's going to be pale, okay? That's autopsy, it can come in OSPI, okay? Histology too. Histology, if you take a histology of the substantia nigra, you're going to see some black spots. It's normal. That's the substantia nigra because of the melanin. In a Parkinson's patient, there's going to be no black spots. Very rarely you'll see the black spots, okay? Histology can also come in OSPI. And please remember the pathology, it's mainly due to asynuclein buildup as part of Lewy bodies, okay? So that's some Parkinson's stuff, okay, information. Here, there's a small mnemonic if you want to remember, smart, shuffling gait. Sometimes you just forget. You think it's easy, but sometimes you forget because you have so many diseases in your mind. When you're reading something, you can remember this, okay? Now let's go back, okay? So this was a slide in your lecture. I just wanted to include it. Why? Because 2 years ago in my batch, I remember Dr. Al-Kawi, I think that's how you pronounce his name. He didn't bring this, but he brought something related to like reflexes and phenomenon related to multiple sclerosis. Hot water, when you're showering in hot water, you get like a sizzling feeling in your spine or something. So I feel like this could be something he brings, okay? The glabellar reflex, what that means is basically if someone taps in between your eyebrows here, the first few times, your eyes might close, but then you can keep it open no matter how much they tap. In a Parkinson's patient, they can't keep it open. It's going to keep closing, okay? The second reflex, a palmomental reflex, what that is if they scratch your palm, their jaw is going to contract. Okay, so these are two reflexes. I feel like the doctor could bring a question on this, because it's more towards the clinical sides of things. Okay, so does anyone have any questions on what I just said? And if I'm talking fast or maybe something, just let me know. Okay, please, in the comments. Yeah. Okay, so I'll move on to the next question. Clear. Okay, thank you very much for replying. Okay, please go ahead and read this. Okay, so before I move on to this question, someone asked a question about Parkinson's. They say any age for Parkinson and AZ specifically. Good question. Alzheimer's and Parkinson's have very different clinical features. So usually it's going to be easy for you to notice that, okay? Like we just talked about the tremor, you don't have that Alzheimer's, you don't have like a stiff body and rigidity. But Parkinson's, the age of onset is usually around 60. You can also have it above 50, but 60 is the average. Alzheimer's, it's most commonly between 70 to 80, but it can also occur between 65 to 70. So the most common ranges is from 65 to like 85, okay? So that's for Alzheimer's. But usually it's easier to differentiate with the clinical features, okay? So now any answers to this? Let me move to the, I won't even, without me seeing the choices. Anyone have any ideas? I'll just show you the choices, okay? So there you go. Okay, so someone thinks it's Alzheimer's, and that's the second best choice. And that's actually good that you thought that, okay? But it's not what it is. It is normal pressure hydrocephalus. Sorry, okay, guys, that I can't go back. Wait, what? Okay, so this is normal pressure hydrocephalus. So what it is, okay, just basically remember with the three letters, okay? Wacky, wet, and wobbly. What that means, okay, wet, it means they have urinary incontinence. What that means is they're gonna pee, they're peeing too much, okay? They have more frequency, more urgency, okay? So that's one thing. The second thing is wobbly. Wobbly, just think about that. What it means, it means, it's just wobbly when they walk. Something wrong with their gait, whether their feet are just stuck to the ground too much, or whether they just walk like they have an abnormal gait. Their gait is not normal. That's the wobbly part. Number three, wacky. Wacky, you think of like someone's head, they're wacky in the brain. They have some mental problems, okay? And here, so let's look at the patient here. She has progressive gait disturbances, okay? You don't really see gait disturbances in Alzheimer's. For example, someone's thinking it's Alzheimer's, okay? The feet are stuck on the floor. That's another sign of a gait abnormality. And she recently began experiencing urinary urgency. So you have two of the three. You have wobbly and you have wet, okay? Now if we keep reading, we'll find the third thing, which is she has difficulty concentrating and she has lost interest in her hobbies and social activities. Listen, when they talk about mental issues, don't always just think it's a loss of memory, okay? It can even be executive dysfunction. I'll explain to you what executive dysfunction means, but it's basically, okay? So here, the mental loss was with what? With concentrating and interest, okay? So you have the three, you reach the three, and then they even gave a CT scan. What's the cause of the disease? Normal pressure hydrocephalus. So there is hydrocephalus, but it's not an abnormal pressure. That pressure is normal. It's just due to an enlargement of the what? The ventricles, okay? The ventricles are enlarged, okay? And the rest of the brain is normal. That's how you differentiate a CT scan of an Alzheimer patient with normal pressure hydrocephalus, okay? The CT scan in normal pressure hydrocephalus, the rest of the brain tissue is going to be normal. The only thing that's going to be enlarged are the ventricles, okay, for NPH. For Alzheimer's, you're gonna have atrophy of the gyri. Okay, it's gonna get atrophied, the gyri. Okay, as a result of that, you're gonna have widening of the sulci. The space in between the tissue is gonna be widened. Okay, and now you have atrophied brain. What happens to the ventricles? They're gonna take the rest of the space and they're gonna come enlarged. Okay, so that's the difference. Here you see it's a normal brain tissue. Alzheimer's would be atrophied here. Okay, and another thing is Alzheimer's, it would not have urinary urgency and gait disturbance, okay, early on in the disease. Later on, maybe. But the first issue is what? Short-term memory impairment. This patient doesn't even have memory impairment. Like there's nothing about her forgetting things. She just have difficulty concentrating, okay? And don't worry, I'm gonna give you a question about Alzheimer's disease in a bit too, okay? So do you guys understand NPH? Let me read what this says. There you go. If you want to read this, okay. Periventricular white matters, okay. Gait difficulties, cognitive disturbances, like I said, different things, okay. Apathy, like lack of emotion as well. And what's the treatment? CSF removal. How? Ventricular peritoneal shunting, okay. That's the treatment for this. So does anyone have any questions? Okay. Thank you. Now, let's move on. This is Alzheimer's. I gave you the answer. Okay, but you probably will realize. Okay, go ahead. Okay, let's read it together. Okay, so an 82-year-old woman comes to the clinic due to memory loss. 82. What are the differentials in terms of memory loss? Okay, could it be Huntington's? Not really. Huntington's usually, it's like you're in the 50s, 60s, 40s. Okay, when it's goes on in the generations. Parkinson's, it could be Parkinson's, although the most average onset is 60. Even at 82, it could occur. Okay, if a doctor really wants to be hard on you, he'll give you 82. But the first thing they give you is memory loss. So you're gonna try to go towards Alzheimer's. Okay. So what type of memory loss? She lives with her daughter, who reports that her mother has had difficulty remembering recent conversations. Look at that, recent. What does that mean? Short-term memory loss. Okay. Alzheimer's first starts with short-term memory loss. They're not going to forget the date of birth, when they were born or where they lived 30 years ago. No, they're going to forget recent conversations, okay? Recent events, such as her grandson's birthday party. 2 years ago, she was forced to give up driving after repeatedly getting lost in her own neighborhood and being involved in a minor motor vehicle accident. You can learn 3 things from this one sentence. Number 1, they said 2 years ago. What are they trying to say? Is that it's progressive. Okay, it's progressive. It's not a rapid onset. It's 2 years. That takes time. Rapid onset's usually a few months. Okay, that's the first thing. Number 2, she's getting lost in her own neighborhood. That's another sign of Alzheimer's. In Alzheimer's, you walk out, you go somewhere, you do not know where you are. You do not know where you are. You do not know what time it is. You do not know what you're doing there. Okay, it's called a lack of spatial something awareness. I forgot the exact word. Okay. So I've seen this example so many times that they're driving around in their neighborhood and they forget where they are. Okay, I've seen that so much. And the third thing is a minor motor vehicle accident. That is also something actually. Now people might actually miss the fact that that's something, but it is. What they're trying to say is that she's forgetting her normal daily functions in life. Okay, so she doesn't just forget her memory of what she did yesterday, what she ate yesterday. She forgets motor function too. So we all know how to wash ourselves. Animals know how to wash themselves. Okay, she's not going to forget how to wash herself, how to eat first. What she's going to forget is the things she learned, the motor functions she learned. Like what? Like driving a bicycle, cooking, driving a car. She starts forgetting that. Okay, she starts to forget how to do her basic living, like her job. She's not gonna know how to do her job. So a question might say she dropped out of her job because she couldn't keep up with her tasks anymore. Okay, so that's and then look what it says next. The patient still enjoys reminiscing about old times with friends and playing bingo at church. So she can still remember her long-term memory. Okay, so that's Alzheimer's disease. So which of the following is the most likely pathological finding? It is, as you guys said, E, okay, neuritic plaques. So that's the pathology behind it. What is demyelinated plaques? A, that's multiple sclerosis. Large intracytoplasmic vacuoles, that's Creutzfeldt-Jakob disease. We're going to be seeing that. Don't worry, okay, guys. Lewy bodies, Parkinson's disease, multiple lacunar infarcts, vascular dementia, okay, and then neuritic plaques is what we're looking for. That's Alzheimer's disease, okay? So let's just read some pathology of Alzheimer's disease. Oh, wait. Okay. So the elderly patient likely has Alzheimer's disease and okay, memory loss, especially at recent. Executive dysfunction. This is what I was talking about. Okay. So executive, this is what executive dysfunction is. These are different skills. Okay, like time management. For example, a patient in Riyadh, مثلا, they'll forget when the prayer times were. They'll miss prayers. They could say that. Like what I'm trying to show you is that Alzheimer's isn't just the most common thing we think of is like, oh, she forgets her son's names and stuff. It's not just that. It's so much more. Task initiation. Okay, like I said, if they're organizing an event or something, they can't keep up with their tasks. They can't do it anymore, okay? Working memory is what you're doing right now. What you're doing right now is you're using your working memory, okay? In 5 minutes, if you remember this slide, that's your working memory keeping, but they're not gonna remember their working memory, okay? They're not gonna remember these slides. So let's just read this second paragraph. This is pathology, which is very important. It's extremely high yield. You're 100% gonna get a question on this. 2000% gonna get a question on this, okay? So histopathological findings of Alzheimer's includes 1, amyloid plaques, 2, neurofibrillary tangles, okay? So the neuritic plaques are extracellular deposits often found in the medial temporal lobe. By the way, that's the first place that's affected by Alzheimer's. The medial temporal lobe, remember that, okay? And are composed of a central amyloid beta core surrounded by dystrophic neurites. So if the question says, that neuritic plaques, what are they made of? You say amyloid beta, okay? They could give you a histopathology picture of the neuritic plaques that you took in pathology, and they say, what's this made of? Amyloid beta, okay? And then, so of course, you guys know that abnormal accumulation is dangerous. And then neurofibrillary tangles are what? They're found in the neuronal cytoplasm and consist of aggregates of hyperphosphorylated tau protein, which normally mediates microtubule stabilization. So this first point is very important. I think we got a question on this in our exam. You have to remember, neuritic plaques are extracellular, fibrillary tangles are intracellular, okay? I said the second thing and third thing. So now we can move on. Any questions on Alzheimer's? And I hope I'm, explaining well. Okay. Okay. So let's move on. So, okay, so this is amyotrophic lateral sclerosis. So this is another case, by the way, it's not related to the last case. So I couldn't find the question on this, but I want to explain to you amyotrophic lateral sclerosis in the most simplest ways. It's a very easy disease to understand, very easy. And they even hardly give questions because it's so easy on this, like, in like the boards and stuff. Basically, ALS, okay, it just damages, okay, look, read the second part. Loss of neurons in the anterior horn, and also atrophy of the lateral corticospinal tracts. So if you remember from your anatomy, if you lose the anterior horn, that's going to lead to lower motor neuron lesions. If you lose the corticospinal tracts, the lateral ones, it's going to lead to upper motor neuron lesions, right? So that's going to lead to the symptoms. You're going to have both. You're going to have both. Just remember this. You're going to have both symptoms of upper motor neuron lesions as well as lower motor neuron lesions together. You don't see that often with strokes, right? Remember, you guys have taken strokes and spinal cord damage. You don't really see that often. It's usually just upper motor neuron symptoms entirely, right? Here, you're going to see both. And the second most important thing, you're going to have completely no sensory involvement at all. No sensory involvement. Sensations completely normal. Normal vibration, normal proprioception, normal temperature, okay? So it's just motor, upper motor neuron and lower motor neuron. So let me give you an example. A patient, he has positive Babinski sign in the right foot. What is that? You're thinking about upper motor neuron symptoms. But in the left foot, they have lower motor neuron symptoms like muscle atrophy and fasciculation, or even in the right hand, like right foot is upper motor neuron, right hand is lower motor neuron. You're thinking, wait, how are both affected? And that's the disease ALS. Okay, that's what it affects. It can also affect cranial nerves. Okay, so you can have symptoms in the face as well. So that's it. Okay, just remember that. Upper motor neuron, lower motor neuron, motor lesions, symptoms, sorry, and no sensory symptoms. Okay. The age is usually like 50s, 60s. I don't know if you remember Stephen Hawking's, he had ALS as well. Okay. And then the management treatment, just remember riluzole. Okay. I don't think you'll get asked this, but just remember that. I mean, for this exam at least. Okay. So that's for ALS. Okay. We hit 3 diseases so far. Of course, there's so much more details I can dive into, but you know, we're on a time limit. So everyone understood ALS? Okay, let's move on. Next question. Okay, so before I answer the next question, someone asked me, do you recommend pharma treatment to learn from neurology lectures? No, I don't. I do not recommend that. In second year at least, look, it depends on your doctors, but from what I remember from second years is that the pharmacology was from pharmacology lectures. They were not from the clinical lectures. You might have some non-pharmacological treatment in the clinical lectures, but for specifically medicational pharmacological treatment, stick to the pharmacology lectures, okay? Especially for Parkinson's and Alzheimer's, because there's 2 different lectures. So someone answered, is this CJD? You're completely right. It's A, prions, exactly, okay? So let's read the question, okay? 57-year-old man hospitalized for aspiration pneumonia. Now, let me just tell you this from now, because you guys might get confused. The aspiration pneumonia has nothing to do with the question. They're just trying to confuse you. It has nothing to do, okay? Until 4 months ago, the patient was healthy, completely healthy, worked as an engineer without difficulty. However, since that time, 4 months, rapid, remember that's rapid onset, he has developed severe confusion, not mild, severe confusion, mood changes, and memory impairment, and had to take medical leave from work. So it's a very rapid onset and very severe onset, okay? The patient is now completely dependent on his wife for toileting, feeding, and general self-care. Like even the basic things in life he can't do anymore within 4 months. Remember Alzheimer's, to forget how to toilet yourself and feed, that takes years. This guy in 4 months, okay? Physical examination shows disorientation and sporadic, jerky extremity movements. What is that? That's basically saying myoclonus, okay? So myoclonus is like jerky movements. It's like this, okay? So just like the whole hand is just jerking up and down, like the whole arm, or even your leg is just jerking up and down, up and down, up and down, okay? And rhythmic up and down, okay? That's jerky extremity movements, extremity, remember, okay? Soon after admission, he lapses into a coma and dies. Like it was that severe that he died within 4 months. Postmortem examination and brain tissue results, widespread neuronal loss with small uniform intracellular vacuoles throughout the gray matter. Small uniform intracellular vacuoles. What that means? That means spongiform. I'm sure you've read spongiform in the lecture about CJD. This is what spongiform means. Vacuoles, okay? And then very important, what are they saying? No inflammatory changes. That's so important to understand that in CJD, there's no inflammation. It's not from bacteria, T cells, no. It's just from prions accumulating and damaging the cells, okay? So unlike in meningitis, there is inflammation, right? There is not here, okay? So that's CJD, rapid onset, memory impairment, severe memory impairment, okay? Rapid onset, severe memory impairment. And number 3 is myoclonus, okay? Jerky movements of extremities, something motor as well, very rapid. What is the cause? Prions, okay? Mutated prions. So this is it. So if we read the second paragraph, associated with a change in structural conformation of prion protein. So prion protein, if it is changed and mutated, it will deposit, accumulate, and damage the cells. Okay, it is resistant to enzymatic degradation and converts other prion protein. Blah, blah. Okay, so can we move on? Okay, let's go. Next question. Huntington, yes, exactly. Now why? Okay, how? Okay, first, let's look at the age. 42-year-old. Can it be Alzheimer's? It's almost completely impossible unless, now this is something you don't need to know. It wasn't in a lecture. Unless they have Down syndrome, there's a higher risk of Alzheimer's and Down syndrome. Actually, I think it was in your lecture in pathology. Remember, Down syndrome is trisomy 21. Okay? It was. Okay, then you have to know that. You have to know that. Very important. Okay? So trisomy 21, the amyloid beta protein is encoded on the 21st gene. So if you have 3 genes, 3 chromosomes, you're just building more of that. And that's why most Down syndrome patients get Alzheimer's at a much younger age, like 40, 50. Okay? So yes, so this is Huntington's. So she came for evaluation of abnormal movements, okay? Involuntary facial grimaces and extremity fidgeting. She has no prior medical or psychiatric conditions, but her husband says she has had frequent anger outbursts over the past year. Almost 90% of the questions, I've seen many questions on Huntington's, I've done like, okay, they will always mention something like this. They will give you some severe movement disorder, okay, involuntary facial grimaces and extremity fidgeting, and then they will hint at a small mental, symptom. Like what are they saying here? Anger outbursts. Instead of anger, they might have depression, okay? They could have anger, they could have depression. These are the 2 most common symptoms of like psychological symptoms that these patients usually have. Memory impairment, like they're forgetting things, is much less, okay? Now, her father died of neurological disorder at age 55. Here, you should automatically know that it's Huntington's. Why? Because Huntington's is passed through generations. Okay, it's not sporadic, it's genetic, it's inherited. Okay, so the question, like, they have to mention that the father has it. They either mention that the father has it or that he was adopted. So they don't know anything about the parents, to try to confuse you. Okay, remember, autosomal dominant. Okay, physical examination shows intermittent fidgety, jerky movements of the hands. Let me show you what that looks like. Here, can you see me? Can you see, can you see the, yeah, you can. Okay, let's watch. So, look, his whole body's moving, his whole body's shaking, his hands, his face. I don't know why it's taking so long to load. But I think you get, okay. This isn't voluntary. This is all involuntary, what he's doing right now. People call it a dancing movement. It's like he's dancing, okay? His whole body's moving. So that for you is Huntington chorea, which is also called Huntington chorea, okay? So yeah, Huntington's disease. Now let's do it a little about Huntington's disease. Autosomal dominant, CAG repeats, okay? Anticipation, I don't know if you took this. I don't want to confuse you with more information. It's kind of biochem. You're definitely going to learn it later, okay? Decrease in GABA, that's also important, okay? Okay, you did take it, okay. So early onset, so look, so in the patient, if you look at the patient, she got Huntington's at 42, but her dad got it at 55. So why did she get it at a younger age? That's because of anticipation, okay? So you get more severe disease in subsequent generations. Why? Because you get more CAG repeats, okay? So that's why I always see a question. The dad's like 60 and he got it, and the patient's like in their 40s, 50s, much younger, okay? Decrease in GABA, very important to remember. GABA and acetylcholine were caudate nuclei. Extremely important to remember caudate nuclei. Why? Because the confirmatory test string, you can see the neuroimaging shows caudate atrophy, okay? The caudate is very important to remember. You know how most diseases affect a certain type of part of the brain, like Alzheimer's affects the temporal part of the brain, substantia nigra is affected by Parkinson's. Please remember that caudate is affected by Huntington's. You can also get it in OSP. Okay, they can give you a picture of the brain, okay, a section of it, and they give you a scenario of Huntington's, and they tell you, okay, A, B, C, D, which part is damaged, and you have to choose the caudate nuclei. Okay, great. So yep, that's for Huntington's disease. Let's move on. Any questions? Okay, let's move on to the next. So you can read this now. Okay. Someone said A, that is the correct answer. Okay, so if you look at this patient, okay, they're having inappropriate sexual jokes, little regard for social rules, is often irritable, and is borderline aggressive. Okay, so these symptoms, they're basically saying that they're losing like social like rules. They're not having any social respect anymore. They do not care about what they say to people. They do not care about their effect on people. They might even go out in the streets and just pee in the streets. Okay, they don't care anything. They don't care about what people think about them anymore. Okay, so that's very, very obvious symptoms of frontotemporal dementia. Okay, now frontotemporal dementia, let's read it here. Patient's personality and behavioral changes, disinhibition, apathy, social inappropriateness, compulsive behaviors, and altered speech patterns. So you have both of them usually together, consistent with the diagnosis of behavioral variant frontotemporal dementia. Okay, now look, I want to explain something to you guys. There are many diseases which the symptoms are very easy to understand, like this disease. Okay, social inappropriateness, you just easily go to frontotemporal dementia. There's no other dementia like that, okay? So the question is not going to tell you what is the diagnosis in this patient. The question is going to dig deeper into the diagnosis itself and take something from that diagnosis and ask you about that. That's what we see here. What are they asking? They're asking which part of the brain it affects, okay? So that's why you shouldn't just know the symptom, you should know almost everything. Like what I'm trying to show you here is how they ask you different questions, and why doing questions is very important, because you see what's important about different diseases, you know? You see like what kind of questions they ask about that certain disease, what they want you to know about that certain disease, okay? So the caudate, let's just look at the other answers. Okay, so anterior temporal and prefrontal, that's like it says here, degeneration of the prefrontal cortex, include the anterior temporal cortex as well. Inappropriate behavior, impaired judgment, and poor problem solving skills. Okay, so let's look at the other options. B, caudate nucleus and putamen. What is that? Exactly, Huntington's. We just mentioned that. Okay, locus ceruleus and substantia nigra. It is what? Alzheimer's disease. Substantia nigra. Mammillary bodies and medial thalamus. What is that? Mammillary bodies and medial thalamus. That is Wernicke-Korsakoff syndrome. Yeah, okay. And then lastly, medial temporal and parietal cortices. E, that is Alzheimer's disease. Okay, so you have to remember that these are the parts affected by the different diseases. Okay, I could change this whole question and make it into a Wernicke-Korsakoff disease, and the answer would be D. Okay, for example. So also use the method of canceling out choices. Okay. Now let's go to this. I think this could be the last question. This is probably the hardest question out of the out of all the questions, probably. Okay, D, great. Okay, that's exactly. So what pointed to vascular dementia? A few things, okay? I think around, okay, let me say, yeah, 3 things pointed to vascular dementia here. One is the fact that he has stepwise decline in function. What does stepwise mean? If you remember Alzheimer's, the patient progressively had decreased, function. So the difference is like between an escalator and the stairway. An escalator is going up like this, right? It's just going up like this. But a stairway, you jump, you go up like this, and then you go up. You just keep going up and up and up, right? It's not like going like a straight slope, right? So what they're trying to say is that Alzheimer's is progressive, okay? But vascular dementia, one thing happens and it affects your function, and then you're good for a while. And then the second thing happens and suddenly you get worse again. And then a few months later, you just get worse again. Like it just keeps getting worse between certain time periods. Why is that? Because of the vascular part of the word vascular dementia, because you keep getting infarcts in different parts of the brains. So every time you get an infarct, a small or medium infarct, you get dysfunction of a different part of the brain. Okay, that's the first part. That's the first thing. The second thing is that if you look at the patient's history, they have so much history of like atherosclerosis and like vascular problems, hypertension, type 2 diabetes, coronary artery disease, even high blood pressure. These are all pointing towards vascular dementia. Vascular dementia always has history of these diseases, okay? At least 1 or 2 of them. They have a very, very bad history of like atherosclerosis and stuff like that. The third thing is if you look at their symptoms, okay? Let's read this, okay? The patient presentation with a relatively abrupt cognitive decline and a stepwise deterioration in function. They started misplacing items, and then suddenly they were unable to manage finances, and then suddenly became lost in familiar places, okay? It wasn't gradually getting worse. It just got suddenly happened over and over. The primary pathogenesis of this disease is atherosclerosis, okay? And then also the last thing, like I said, is the multiple deep white matter lesions on cranial MRI. What they're trying to say is it's everywhere. It's everywhere in the brain. Everywhere is affected. Okay, you get infarcts, small infarcts in almost every blood vessel. And then when you get the infarct of that blood vessel, that part of the brain is affected, and then you get a certain pathology according to that brain, or that part of the brain, okay? So that's for vascular dementia. And that's it. So that's for all my questions today. I hope I helped you understand. So just a quick summary. We had Parkinson's, normal pressure hydrocephalus, Alzheimer's, okay? Normal pressure hydrocephalus, remember, wet, wacky, wobbly, normal cortex, enlarged ventricles. Done. Alzheimer's, okay? First, short-term memory impairment, okay, in a patient who's like above 65. The pathogenesis is due to what? Senile plaques and neurofibrillary tangles due to the beta amyloid protein, okay, being cleaved in a wrong way by the beta enzyme, okay? And what do you see grossly? Atrophy of the gyri, widening of the sulci, and then you get enlargement of the ventricles, okay? And then Parkinson's disease, remember, it first starts with motor symptoms. You get the tremor, the rigidity, the gait, and then after a while, they might get, memory impairment too, okay? ALS, very easy, just motor symptoms, upper motor neuron and lower motor neuron, no sensory symptoms, okay? And then we had vascular dementia just right now, Huntington's, remember too, okay? Family history is very important. And then they have jerky movements, okay? The chorea I showed you about. And then like little psychological impairment. And that's it. So that was for the lecture of degenerative diseases. I think I tried to cover the most important parts of that lecture. I think you'll only bring one question on that lecture, okay? There was something about Friedreich ataxia as well. I felt like I thought I didn't have enough time to bring something on that. That's more kind of biochem, actually. I don't know if you'd bring a question on that, though. But I mean, if we're being honest, the only, what's it called? The only disease out of these diseases that will affect younger people is Friedreich ataxia. Okay, it's going to affect younger people in like their tens, second decade and third decade of their lives. Okay, and that's it. So, any questions? When's your exam, guys? 2 weeks? Okay, so it's in 2 weeks. So I'm just gonna give you my biggest advice. I gave it to you before. Please do questions. Notes aren't gonna help you as much as questions. I see a lot of people just writing notes. I regretted doing that in first year. When I switched to doing questions, my grades skyrocketed. Okay, so do a lot of questions, as many as you can. Look, when you do a question, okay, and then you read the explanation, you're learning. It's like you're reading the slide. Okay. So you might ask, Omar, where can I do questions from? You have Robbins. So Dr. Abrar loves taking questions from the Robbins review, okay? And it has very good explanations as well. Very good. You also have Amboss. Do you guys use Amboss? Just a question. Do second year use Amboss? Okay, we do. Use Amboss a lot. Amboss is amazing. Without it, I wouldn't have had, yeah, amazing. Amboss, especially for studying, okay? Yeah, great, okay? And then the best out of all three, I would highly recommend UWorld. All the questions I got were from UWorld. Okay, you have all these free resources at your hand. Other universities don't have this. Take benefit of it, okay? And you'll be very grateful from that. Okay, questions. I promise you, it'll help you a lot. Okay, inshallah. So we're done. Thank you very much. Assalamu alaikum.